This lecture is going to discuss parameters and trade-offs. The objectives for this lecture are to define the 4 pillars of image quality, differentiate signal versus noise, discuss parameters that influence signal-to-noise ratio, discuss parameters that influence spatial resolution, discuss parameters that influence scan time, compare contrast-to-noise ratio to SNR, discuss factors that affect contrast-to-noise ratio. Protocol optimization enables us to maximize image quality and acquire diagnostic images in the shortest scan time. There are many extrinsic and geometric parameters available for an MR technologist. An MR technologist needs to understand how each parameter affects SNR, spatial resolution, or scan time, along with their possible negative trade-offs. Depending on the patient or pathology, an MR technologist needs to juggle these parameters to achieve optimization. For example, if you have a claustrophobic patient, you're going to need to reduce the scan time. For a patient with a hairline fracture within the wrist, MSK procedures usually need high resolution and high signal. For a patient with a metastatic brain lesion, a good contrast to noise ratio is optimal. 4 pillars of image quality. First is SNR, which is the ratio of signal amplitude, which can be adjusted and is predictable, to the average amplitude of the noise, which is random. Ideally, you want your SNR to be high. CNR, which is the difference in SNR, or shades of gray, between 2 adjacent pixels. Ideally, you want your CNR to be good. Spatial resolution, or recorded detail, is the ability to detect 2 points as separate and distinguishable. Ideally, you want your spatial resolution to be high. And finally, scan time, which is the time to fill K-space. And for a conventional spin echo pulse sequence, the scan time equation is TR times phase encoding steps times next. And ideally, you want your scan time to be short, because if your patient moves with the scan time that's too long, no matter what you do to your signal or your spatial resolution, your image quality is going to be bad. Signal-to-noise ratio is defined as the ratio of the amplitude of the signal received to the average amplitude of the noise. Signal is the voltage induced in the receiver coil by the precession of the net magnetic vector in the transverse plane, m sub xy. Noise is the frequencies that exist randomly in space and time. And noise depends on patient body habitus, area of interest, and the inherent noise of the system. Signal can be increased or decreased relative to noise. Parameters that influence SNR can be divided into 4 categories. Hardware parameters include static magnetic field strength, B sub 0, receiver coil type. Contrast parameters include TR, repetition time, TE, echo time, flip angle, and pulse sequence type. Sampling parameters include NSA, NEX, or number of acquisitions, which all mean the same thing. Receiver bandwidth. Voxel volume parameters include field of view, matrix, and slice thickness. Now let's go into more detail how each parameter affects SNR, starting with hardware parameters. Static magnetic field strength, B sub 0. As B sub 0 increases, less hydrogen spins can oppose a stronger static magnetic field. So less spin downs means more spin ups, and the excess spin ups increases the net magnetic vector. As the net magnetic vector increases, so does the SNR. There's a direct relationship. As you can see from the image to the right, with a 3 Tesla magnet, you get higher signal in the white matter and in the fat compared to a 1.5 Tesla, where the white matter and the fat are not as hyper intense. With the 3 Tesla, since you have more magnetization to play with, you can also play around with your matrix and your NEX to increase your resolution and reduce the scan time. The trade-offs for an increase in static magnetic field strength is that you're going to increase your RF deposition, which means you're going to increase your SAR. That's because you're transmitting at a higher frequency. For a 3 Tesla magnet, you're going to be transmitting at 128 megahertz, which is calculated through the Larmor equation, compared to the 1.5 Tesla magnet where you're going to be transmitting at half that, 64 megahertz. Receiver coils can receive RF energy. Surface receiver coils are placed directly on the region of interest. Maximum sensitivity is directly related to proximity to the part. That's why you see receiver coils shaped like the anatomy of interest, as you can see here with this chimney coil, which is designed to be placed around the ankle and foot of the patient. Diameter, proper placement. As you can see from the image to the left, when the coil is perpendicular to B sub 0, you get the most signal coming from the patient, as you can see with the top image and the bottom image. But when the coil is placed at an angle not perpendicular to B sub 0, you're going to get less signal. And finally, multiple channels or coils. Here we have an image with a 2-channel knee coil versus a 16-channel knee coil. You can see that you have higher signal with the 16-channel knee coil, which allows you to play around with your matrix and your scan time as well. With the quadrature coil, you have 2 receiver coils that are perpendicular to one another, as you can see from the image to the right, where you have these 2 coils, 6 and 5, that are 90 degrees to one another. That allows you to capture 2 free induction decays or echoes. This increases the signal to noise ratio and the volume of tissue covered. The signal is going to increase by about 40%, hence the name quadrature. Phased array coil is comprised of multiple smaller surface coils to detect changes in phase of spins. It increases the SNR and volume of tissue covered. It activates specific sections, and then you can also deactivate others not in use, as you can see from the image to the right, where you have activated the C-spine portion and deactivated the T and L spine. Linear phased array spine coils permit parallel data acquisition, aka parallel imaging. Each coil element simultaneously contributes data to K-space, reducing the scan time. Now let's discuss how contrast parameters affect SNR. Repetition time, TR. TR controls the amount of longitudinal magnetization, M sub Z, allowed to recover before the next excitation pulse is applied. As you increase TR, more longitudinal magnetization is available to be flipped with the next RF excitation pulse. As you can see here with the T1 recovery curve, as fat and water both recover up the longitudinal plane, as you increase your TR, these tissues are allowed to fully recover up to their original height, or 100% recovery. So as you increase your TR, you're going to increase the amount of signal up to a point, because you can't ever recover past its original value or past 100% recovery. With a short TR, you're going to have less longitudinal magnetization available to be flipped with the next RF excitation pulse. So with short TRs, you can see here both fat and water are only allowed to recover partially, so when the next RF pulse comes along, smaller vectors of those tissues will be flipped into the transverse plane and less signal. So you can see the relationship here. As you have a shorter TR, you're going to have less SNR. The trade-off for an increase in TR is that you're unfortunately going to increase your scan time, because there's a direct relationship between the two. Here are 2 images showing how you increase your TR, you're going to get an increase in signal. The image to the left shows you 3 axial branes with different TRs. On the left you have a TR of 200, and you can see that the image has low signal and quantum model, some graininess. But as you increase your TR up to 500 or even to 1000, you can see all these tissues are starting to have a higher signal intensity. And then the image to the right shows sagittal brain with different TRs. And you can see here, image D has the lowest TR because you have the lowest amount of signal, and then going up accordingly to image A, which has the highest amount of signal because the TR is the longest. Echo time, TE. TE controls the amount of transverse magnetization allowed to decay before the echo is collected. As you increase your TE, more transverse magnetization decays before the echo is collected. As you can see here with this T2 decay curve, both fat and water have a longer time to dephase, meaning those spins are going to be more incoherent, which reduces the overall signal from those tissues. So increasing your TE actually decreases your SNR. There's an inverse relationship. But as you can see with a shorter TE, you have less transverse magnetization decay of these tissues before the echo is collected. So overall, you'll keep the signal by having a shorter TE. And this is why T1 weighted and proton density weighted images have more signal than T2 weighted, because these two types of image weightings have short TEs associated with them. So their overall signal is higher than a T2 weighted image, which has a long TE. Here are two images showing this relationship between TE and signal. And since it's an inverse relationship, you can see from the image to the left, with a shorter TE, you actually have more signal. So here your TE is 76 milliseconds and you have high signal. But as you increase your TE, those tissues quickly dephase and lose signal, and the signal overall is less here with a 150 millisecond TE. And the image to the right shows you this relationship as well, where A now has the shortest TE, but the highest signal. But as you increase your TE accordingly, image D has the longest TE and the least amount of signal. Flip angle. For a spin echo pulse sequence, a 90-degree flip angle is desired because the entire net magnetic vector is flipped into the transverse plane, which is where the receiver coil is located, giving you maximum signal amplitude. From the image to the left, you can see two different flip angles. With the 90-degree flip angle, you flip that entire net magnetic vector into the transverse plane, which increases the amount of signal. But with a 30-degree flip angle, only a portion of the net magnetic vector will flip into the transverse plane, and a smaller net magnetic vector in the transverse plane results in less signal. Now for a gradient echo pulse sequence, the desired angle is the Ernst angle due to short TRs associated with gradient echo pulse sequences. And TRs have to be short with gradient echoes to prevent saturation. So for a specific tissue with a given T1 relaxation time and TR, the flip angle, which will result in the maximum signal for that tissue, is the Ernst angle. Over here you can see two different images with two different flip angles. The flip angle of 10 degrees, you can see that only a portion of that vector flipped into the transverse plane, leaving you with less signal, and you have a lot of noise in quantum model on this image. But then over here with the 90-degree flip angle, and most likely this is a spin echo pulse sequence, you get high signal because the entire net magnetic vector had flipped into the transverse plane. Pulse sequence type. Let's compare spin echo versus gradient echo in terms of signal. Spin echoes typically have a 90-degree flip angle, which increases your signal, as you saw in the previous slide. It also has a 180-degree refocusing pulse, which corrects for three artifacts: magnetic susceptibility, chemical shift, and inhomogeneity, which all result in an increase in signal-to-noise ratio. And the TRs for a spin echo are typically longer, so the overall signal is also increased. The trade-off is, unfortunately, as you increase your TR, you're going to get longer scan times. But that's okay if you're concerned with having higher image quality, as you can see with this axial abdomen, which has high signal within the tissues. You can see this cyst within the kidney very well. You also get high signal within the retroperitoneal fat, good contrast to noise, and high signal. Now let's compare that to a gradient echo, which typically have a variable less than 90-degree flip angle to prevent saturation, and this decreases your signal. You also have no 180-degree refocusing pulse, which do not correct for these artifacts. The gradients are actually responsible for refocusing the echo, which are not as efficient at correcting for these artifacts. So overall, the signal goes down. And the TRs are shorter. So with a short TR, you're not allowing those tissues to fully recover, which reduces the signal-to-noise ratio. The trade-off, which is good for gradient echoes, is that you have shorter scan times. So you're able to image while the patient is holding their breath, for example. But you can see from this image to the right that the overall image quality has been reduced, and you get several artifacts on this axial abdomen, starting with this India ink artifact. And the overall signal from this image compared to this one is less. Now let's discuss sampling parameters and how they affect SNR. Number of signal averages, NSA, aka number of excitation or number of acquisition. This is vendor specific. NSA controls the amount of data stored in each line of K-space. Or you can think about it as how many times you go back and refill K-space. Data contains signal and noise. Signal is not random when it's collected and stored in K-space. It occurs at the same place when collected at TE, or echo time. Noise is random. It's going to occur at a different position in K-space each time the data is stored. So increasing your NSA does not mean signal to noise will increase directly proportional, because noise is random. So signal will increase in relationship to the square root of NSA. For example, if NSA is increased from 1 to 4, you take the square root of 4, which is 2, and that's how much SNR is going to increase. However, scan time is going to increase by a factor of 4 because NSA is in the scan time equation. You can see this relationship over here to the right. With an NSA of 1, the signal is 1, but as you increase it to 4, you're going to take the square root of 4, so the signal only jumps up by a factor of 2. And you can see this is not really the best way to boost your signal because it eventually will plateau out. So if you increase your NSA all the way up to 16, which is not reasonable, your signal is only going to increase by a factor of 4. Here are two images showing you this relationship. This axial brain with a small field of view has a next of 1, meaning there's not much signal. And you can see that with how grainy the image looks. But as you bump up your next to 4, and remember, you take the square root of 4, which is 2, so the signal here is doubled compared to the image to the left. You're able to see these structures with higher signal, but is it worth it? Because now we have quadrupled our scan time. And then over here we have the same relationship. We have a sagittal brain with an NSA of 1. You can see the image is pretty signal starved, and there is some motion artifact on this mid-sagittal slice. As you increase the NSA to 4, it averages out the noise or the motion artifact, which is good, and it bumps up the signal, but by only a factor of 2. And the scan time is now 4 times as much. So you always have to think about, is it worth it to bump up the NSA? Receiver bandwidth. Receiver bandwidth, by definition, is a range of frequencies sampled during application of frequency or readout gradient. With a narrow receiver bandwidth, you apply a filter to the frequency encoding gradient. You can see here where you're going to be collecting more of the signal by applying this filter and filtering out the noise, which is on the periphery of the signal collected. So as you narrow or reduce the receiver bandwidth, you're going to increase the signal to noise ratio by pretty much eliminating the noise. So this ratio increases. The trade-off is you're going to increase your signal, which you can see here. The signal is very good in the posterior part of the C-spine, but unfortunately you're going to get more artifacts associated with this. You're going to get an increase in chemical shift, magnetic susceptibility, and inhomogeneity. And you can see that magnetic susceptibility artifact right here where you have a large amount of distortion caused by metal within the teeth. Now let's compare that to a broad receiver bandwidth. Here with a broad receiver bandwidth, you're not really applying that filter and you're still collecting some of the noise on the periphery. So the overall signal to noise ratio goes down. The trade-off here, which is good, is that you are able to average out some of these artifacts like chemical shift, magnetic susceptibility, and inhomogeneity. So let's compare the two images now. You can see that this image with a broad receiver bandwidth has less signal. The tissues are not as hyper intense, but the metal artifact is blooming out less. So you've contained this artifact into a smaller area, which is good sometimes when you're scanning areas where you know that there's metal within the body. Voxel volume and its effect on SNR. Let's define a pixel and a voxel. A pixel, which you can see here in red, is the building unit of a digital image, and its unit is millimeters squared. A voxel, which you can see here in gray, is a unit of volume of patient tissue, and the unit is millimeters cubed. The brightness of the pixel represents the strength of MR signal generated by the voxel. So you can think of it as how many hydrogen spins within this unit of voxel will be represented by the shade of gray that is produced on this pixel. So more hydrogen spins means you're going to get a more hyper intense pixel. Less hydrogen spins, you're going to get a hypo-intense pixel. Let's further discuss pixel versus voxel. Pixel is two-dimensional, and it is determined by the field of view in the matrix. The pixel size is calculated using this formula. Field of view divided by the frequency matrix, or the number of columns, times field of view divided by the phase matrix, or the number of rows. So for example, if you have a field of view of 240 millimeters, and the matrix is 312 by 256. And remember, the smaller number is always going to be your phase direction because you want to reduce your scan time. So you take these numbers, you take 240, which is your field of view, divided by 256, times 240 divided by 312. And this comes out to 0.72 millimeters squared. And remember, your unit for pixel size should always be millimeters squared. Now let's talk about a voxel, which is three-dimensional. It is determined by pixel size and slice thickness, or the depth of the voxel. The voxel size is calculated by taking pixel size and multiplying it by the slice thickness. So for example, we take the pixel size from over here, 0.72 millimeters squared, and multiply it by the slice thickness, which is 3 millimeters. So 0.72 millimeters squared times 3 is equal to 2.16 millimeters cubed. And remember, the unit for voxel should always be millimeters cubed. Let's differentiate a coarse matrix from a fine matrix. A coarse matrix is when you have a low number of phase encoding steps and frequency encoding steps. Or you can think about it as a low number of pixels within the field of view. When you have a small matrix, like a 232 times 232, you're going to have large pixels, as you can see here. A large pixel will contain more of these hydrogen spins, which increases the overall SNR. The trade-off, unfortunately, is as you increase the pixel size, you're going to reduce the spatial resolution. Now let's compare that to a fine matrix. A fine matrix has a high number of phase encoding steps and frequency encoding steps, and that will equal a large number of pixels within the field of view. A large matrix equals small pixels, as you can see here. With a matrix of 512 by 512, the overall size of the pixel reduces. Small pixels contain less hydrogen spins within them, and that decreases the overall signal-to-noise ratio. Let's continue on this path of comparing parameters with a thick slice versus a thin slice. Slice thickness is also referred to as the voxel depth. A thicker slice, as you can see here with a 10 millimeter slice thickness, will contain more of these hydrogen spins. And as you saw from the previous slide, that will increase the SNR. The trade-off, unfortunately, is as you increase the depth of the voxel, you're going to reduce the spatial resolution. Thinner slices, as you can see here with a 5 millimeter slice thickness, will contain less of these hydrogen spins, which will reduce the SNR. Field of view, FOV. This is the box surrounding the matrix. It is the factor with the single greatest impact on SNR. So if your image is really signal starved, increasing your field of view might be your best option. Simply by doubling the field of view when the matrix remains the same, you're going to increase your SNR by a factor of 4 because you're not only doubling the height, but you're also doubling the width of each pixel. So that's why you're going to increase your SNR by a factor of 4. So you can see here from these two images, on the left you have a sagittal brain using a square field of view of 120 millimeters. And you can see that the signal is very low. It's a lot of graininess within this image. And as you double your field of view to 240, you're going to cover a lot more. Your signal is really going to increase. And it increases by a factor of 4 because each pixel is now 4 times the size. So you're going to be able to capture more of those hydrogen spins within each pixel, so the overall signal goes up by a factor of 4. The trade-off, unfortunately, is as you increase your field of view, when the matrix stays the same, you're going to reduce your spatial resolution. So in summary, to optimize SNR, you're going to increase the static magnetic field strength, which will also increase your net magnetic vector. So if you have an option of working on a 1.5 Tesla versus a 3 Tesla, you should choose the 3 Tesla if you're concerned about signal. Receiver coil type. 4 things are factored into this. Proximity to part, diameter, proper placement, and multiple channels are always better. For contrast parameters, you should increase your TR. Increasing your TR will increase your SNR up to a certain point, because remember, you can never exceed its original value. You want to decrease your TE, or echo time. And that is why a T1 and a proton density weighted image has a higher signal than a T2, because their TEs are shorter. For a flip angle with a spin echo pulse sequence, 90 degrees is desired because you're flipping the entire net magnetic vector into the transverse plane. But for gradient echo pulse sequences, which typically have shorter TRs and you're worried about saturation issues, the Ernst angle is desired because that factors in the T1 relaxation rate of a tissue compared to its TR. And for pulse sequence type, for higher signal, you go with a spin echo pulse sequence because it has a 90-degree flip angle. It has a 180-degree refocusing pulse to correct for artifacts, and the TRs are typically longer. For sampling parameters, you want to increase your NSA, but remember this is not the best option for increasing signal because you're only going to increase it in relationship to the square root of NSA. You want to narrow or reduce your receiver bandwidth to filter out the noise. And in terms of voxel volume, you want to increase your field of view, use a coarse matrix versus a fine matrix, and increase your slice thickness. The second pillar of image quality is spatial resolution, which is the ability to resolve one structure from another on an image. It is controlled by voxel size, which is determined by field of view, matrix or number of pixels, and slice thickness. Let's compare a coarse matrix to a fine matrix in terms of spatial resolution. A coarse matrix means that you have a low number of phase encoding steps and frequency encoding steps, which equals a low number of pixels within the field of view. A small matrix like 128 by 128 equals large pixels. Large pixels reduce spatial resolution. As you can see here with that matrix of 128 by 128, it is hard to see the sharp edges of the vertebral bodies. It's also hard to see the sharp edges of the spinal canal. So these structures are starting to blur together, reducing the spatial resolution. Now let's compare that to a fine matrix, which has a high number of phase encoding steps and frequency encoding steps, which equal large number of pixels within the field of view. A large matrix like 512 by 512 equals a small pixel. Small pixels increase your spatial resolution. So you can see here now with a matrix of 512 by 512, you can see the sharp edges of the vertebral body and the spinal canal. There's no blurring, so the overall spatial resolution is better. However, the trade-off is that this image with smaller pixels has less signal than over here. Now let's compare a thick slice versus a thin slice and how that relates to spatial resolution. Slice thickness, once again, is called voxel depth. With a thicker slice, like you see down here, which is 6 millimeters, you're going to get a reduction in spatial resolution. So it's hard to see that sharp border between white matter and the CSF within the ventricle here. They're starting to blur together. Compared to a thinner slice of 2 millimeters, you're going to get an increase in spatial resolution. So now you can see that border very well defined. The downside to having better spatial resolution is, once again, your signal is going to be lower than over here. However, one good thing is that it reduces the chance of partial volume artifact. So with a larger voxel in terms of slice thickness, partial volume artifact is always an issue. What that means is with a large voxel, you get a lot of tissues within that voxel. And those tissues then get averaged together and present as one shade of gray at the front of that voxel or within that pixel. And sometimes if you have a very small metastatic tumor within those tissues, it can get averaged out. Field of view, FOV, and how it relates to spatial resolution. Field of view, once again, is the box that surrounds the matrix. Doubling your field of view, as the matrix remains the same, will increase your pixel size by a factor of 4. So you can see here, as you double the field of view, the pixel size over here is 4 times as large than over here, because you're not only doubling the height, but also you're doubling the width. As a result, you're going to decrease your spatial resolution. So you can see here with an axial brain with a field of view of 100, you get good spatial resolution because the pixels are smaller, compared to over here where you've doubled your field of view to 210 and you're able to cover more, but your spatial resolution is lower, so all these tissues are starting to blur together. Square versus rectangle pixels. A square pixel is obtained by choosing a square field of view and an even matrix. The result of doing this is going to increase your spatial resolution with the ability to reformat in other planes without losing resolution. compared to a rectangle pixel, which is obtained by using a rectangle field of view and an uneven matrix. The result here is a reduction in spatial resolution. However, scan time can be reduced because the phase encoding steps, which are now 128, are reduced. Rectangular field of view is utilized when anatomy is a lot smaller in the phase direction compared to the frequency direction. An example of this is long bones and the lumbar spine. Rectangular field of view eliminates unnecessary phase encoding steps while maintaining spatial resolution and reducing scan time. So you can see here where all the phase encoding steps have been used, like over here. And then if you want to eliminate the unused phase encoding steps, because the anatomy is shaped in a more rectangular fashion, you're not going to lose any of the resolution because you're just really kind of getting rid of these phase encoding steps that would not be used in the first place. So you're saving time, maintaining the same spatial resolution. So in summary, to optimize spatial resolution, you decrease the field of view, you increase your matrix using a fine matrix, decrease slice thickness, use square pixels over rectangular pixels, and utilize a rectangular field of view whenever possible, like when scanning long bones or the lumbar spine. The third pillar of image quality is scan time, which is the time to complete data acquisition or time to fill K-space. Factors affecting scan time include repetition time, which is the length of time between excitation pulses. As you increase your TR, you are going to directly increase the scan time. Phase matrix, which are the number of rows in K-space. As you increase the phase encoding steps, you're going to increase scan time. And number of signal averages, which is the number of times K-space is filled. As you increase NSA, you're going to increase scan time. Now let's calculate scan time for a conventional spin echo, a fast spin echo, and volume imaging, starting with the conventional spin echo, which is abbreviated as CSE. The scan time equation for a conventional spin echo is TR times phase encoding steps times NSA. So for example, what is the scan time when the TR is 500 milliseconds, the matrix is 512 by 484, and NSA equals 2? The scan time equation would be then 500 times 484, because that's the phase matrix, times 2, which equals 484,000 milliseconds. You divide that by 1,000 to get it into seconds, which equals 484. Then you have to convert it from seconds to minutes by dividing it by 60. That equals 8.07 minutes. And anything past the decimal has to be converted back into seconds. So 0.07 is then multiplied by 60 seconds to equal 4.2 seconds. So the final answer is 8 minutes and 4.2 seconds. Now let's calculate one for fast spin echo, which is abbreviated as FSE or TSE for turbo spin echo. The scan time equation here is the same as before, but then you're just going to divide it by the echo train length, which are repeated 180 degree refocusing pulses. So in this example, the only thing that has changed is you have an echo train length of 4. So the scan time equation is equal to 500 milliseconds, which is the TR, times the phase encoding steps of 484 times 2, divided by 4. And this equals 121,000 milliseconds. And you have to then convert it to seconds by dividing it by 1,000, which equals 121 seconds. Divide that by 60, which equals 2.02 minutes. And then anything after the decimal has to be converted back to seconds, which equals 1.2 seconds. So the final answer is 2 minutes and 1.2 seconds, which is 4 times faster than the conventional spin echo, which makes sense because our echo train length was 4. So everything over here was just simply divided by 4. And then finally, volume imaging, which is denoted as 3D. The scan time equation here is TR times phase encoding steps times NSA times the number of slices. So what is the scan time when the TR is 300 milliseconds, matrix is 312 by 196, NSA equals 2, and the number of slices is equal to 5. So you plug those in for the scan time. So 300 times 196, which is the phase matrix, times 2 times 5, which equals 588,000 milliseconds. You divide that by 1,000 to get it in seconds. 588 seconds is then divided by 60 to get it into minutes, 9.8 minutes. And then anything after the decimal, which is 0.8 minutes, has to be converted back to seconds by multiplying by 60. So your final answer is 9 minutes and 48 seconds. It's important to remember there are some factors that do not affect scan time because they're not part of any of these equations. And those parameters are TE, frequency encoding steps, slice thickness, and field of view. So in summary, to optimize scan time, you want to reduce your TR, reduce the phase encoding steps, reduce the number of signal averages, use a fast spin echo to reduce scan time, because if you increase your echo train length, you're going to decrease scan time, and finally reduce the number of slices. Because if you reduce the number of slices in a 3D acquisition, you're going to reduce scan time. The final pillar of image quality is contrast to noise ratio. CNR is the ability to differentiate between areas of high and low signal, or SNR between two adjacent structures. High signal means the tissue appears hyper-intense. Low signal means the tissue appears hypo-intense. CNR cannot be measured. It's more subjective. It's really the eye's ability to distinguish tissues as different shades of gray. Here you have two images with different CNR. This image to the left has low contrast to noise ratio because it's hard to differentiate between the white and gray matter because they're almost the same shade of gray. Compared to over here, you have high contrast to noise ratio because you can really differentiate between the white and gray matter structures. CNR allows the radiologist to discern lesions from normal tissue. Factors that affect CNR. Image weighting. With T2 weighting, you get better contrast to noise ratio because pathology commonly includes a fluid component, and fluid is hyper-intense on T2 weighting. As you can see with this lesion here in the liver on this T2 weighted scan, which appears hyper-intense, so the contrast to noise between the normal liver tissue is high. Compared to down here with a T1 weighted image, it's hard to see that lesion with the background of the normal liver tissue because they're almost the same shade of gray. Contrast also affects CNR because gadolinium contrast increases the T1 relaxivity of tissues in close proximity. Here's a great example of how a non-contrast tissue here in green will then receive contrast, and it will shift that relaxation curve to the left, causing those tissues to recover faster and appear brighter on a T1 post-contrast image. Chemical pre-saturation, aka fat set or even Dixon. This completely saturates signal from fat to better visualize the lesion. Here you can see how the RF pulse is applied to the precessional frequency of fat specifically to completely saturate it. Here this T2 weighted image is also fat setted to reduce signal from fat to better visualize this lesion within the liver. So if everything is dark except for the lesion, it's easier to see that lesion. Magnetization transfer coherence, MTC. This suppresses signal from white and gray matter, which includes macromolecules, in the brain tissue to better visualize the bright vasculature. So here you did not utilize MTC, and the white and gray matter are still hyper-intense, which makes it hard to visualize the circle of Willis. But then MTC is applied, suppressing the signal from those tissues so that all you see is the vascular structures. And finally, flow-related techniques like time of flight and phase contrast MRV, where you get a difference between stationary tissue, which gets saturated out, and flowing fresh blood, which will appear hyper-intense.